review, now that I am the closest test on the horizon, definitely you're probably more concerned about this material than if I had done this Thursday morning last week. So, so in this test, you're going to notice a difference compared to the first one. The first one was very pathophysiology kind of heavy. It's not going to be that way with this. It's going to be more diagnosis and management, treatment guidelines, and those kinds of things. Because ultimately, that is what should be maybe new material for you, but also with this material, trying to get you to actually think like a provider and how you actually will take care of a patient. You understanding the physiology of what's going on in the kidney, maybe not as important, although the RAS system is important, I will say that. So, but you're going to notice that the questions, the vignettes are going to be longer. So what some folks struggled with last semester is actually just being able to read the vignette in the minute and a half that you get. They weren't able to actually finish on time or get through all the test questions on time. So make sure you are reading the vignettes, but kind of being a little quicker about it because I don't want you running out of time because you were slow in reading it. So the vignettes will be longer. There'll be a lot more reading, but I have to put all that information into your vignette to be able to really steer you towards the right answer. Because so many times, you're going to read a question and the fork in the road can really go in 3 different ways, but there's a reason why one is more correct than the other. And I have to be able to give you that information. I can't have you just guess that that's the information, right? So that means more information in the vignette. So yeah, just be on the alert that the biggest thing you're going to notice with this test is more management diagnosis type questions, less physio or pathophys type questions, and then the vignettes being longer. So, if you looked at the slide count, you'll see that there's 223 slides of important information in this block. The vast majority of those are because of the peripheral arterial diseases and peripheral vascular venous diseases. So a lot of that is that, but there's also a lot of important information that you need to know to be able to do this test. So a lot of this I'm going to kind of, with the lab that we did on Friday, we reviewed a lot of this material already, so I don't think we need to go into an in-depth discussion about these topics. If you do have questions, please don't hesitate to raise your hand if I'm going too fast or you don't quite understand a point to that. Please raise your hand so I can take the time necessary to address that. The only topic that we didn't really address on the lab was the peripheral vascular diseases, so we'll probably spend a lot of time looking at those slides, that information, since we didn't really review that stuff in the lab. Does that make sense? Is that agreeable to everybody? Okay. So please don't hesitate if you have a question on something to have me go through that information more in depth. So with hypertension, again, big thing is just knowing kind of the definitions per the ACC-AHA guidelines. So for the different types of blood pressure, stage 1, stage 2, those types of things. I don't necessarily need you or want you to understand this one or this one, but what is stage 2, what's stage 1, what's considered a normal blood pressure. Those ones are important to know, but I don't want you to memorize the JNC guidelines. I don't want you to memorize the ISH guidelines for this. And then the other thing is it's more than just one blood pressure that's abnormal. You have to have a couple of different readings at different times. So you can test them today and then bring them back tomorrow, or you can bring them back next week. That would qualify as a diagnosis of hypertension. It can't be you check it today, 2 minutes later you check it again and it's high. There you go, you have hypertension. So, of course, then just knowing that there is primary and secondary hypertension. This one being the most common that we see. Secondary, again, there's another medical condition going on that's causing the hypertension to be a symptom of that condition. So treating the problem first will help manage the blood pressure. Other definitions, so what's white coat hypertension? So again, in the office they have elevated, but it's normal at home. Masked hypertension is normal in the office, but abnormal at home. And then if somebody who is on multiple medications and you're still not controlling it, this is called resistant hypertension. And the importance with that is that they're compliant with the treatments. Ambulatory blood pressure monitoring is a great way to kind of help diagnose, because it not only will eliminate the concern for white coat hypertension, but it also gives you a lot of different data points that you can actually objectively show the patient that they have this diagnosis. Problem with we don't use this more is just because of it's cost prohibitive. Patient goes home with this for a period of time. You trust and hope that they don't break the machine. You also hope that they'll bring it back for you to actually get your data. But this is a good monitoring device to help you with the diagnosis of high blood pressure. When you do have somebody with hypertension, okay, it's great to obtain a history, looking for maybe secondary causes, looking for genetic kind of conditions, if there's a extensive family history of it. But when you do have somebody with a new diagnosis, there's some labs that you're going to want to get, because you're going to be looking to see, one, is there any evidence of organ damage, the kidneys are not functioning properly? What are other risk factors related to their ASCVD, and because that's going to maybe help you with your treatment goals and guidelines if you are able to really truly classify that patient. Kidneys are important. For primary hypertension, the kidneys play a major role in it. So kidneys. Lots of things that kind of are part of the kidney to affect the blood pressure. But it's more than just kidneys, because it also comes down to the sympathetic and parasympathetic nervous systems having direct impact not only in affecting cardiac output, but also the peripheral resistance of the blood vessels themselves. Again, blood pressure is made up of your cardiac output multiplied by your peripheral resistance. And there's lots of different factors that kind of interplay with each other to regulate this blood pressure, to hopefully maintain a high enough blood pressure to keep perfusion adequate to all the organs, but not too high that it's causing damage to the organs. Secondary hypertension, so lots and lots of different causes for this. Again, secondary hypertension is not as common as primary hypertension, but your patients can be very difficult to manage if this is one of the conditions that's causing the blood pressure to be elevated. There are the renal causes, which tend to be some of the more common forms of secondary hypertension. There's problems with the vessels leading to the kidneys, so renovascular disorders, which renal artery stenosis is the most common, and think of atherosclerosis. So anybody who has risk factors for atherosclerosis, be thinking of this patient if they have uncontrolled hypertension. If it's a younger female patient, be thinking of fibromuscular dysplasia of the blood vessels themselves. Now, the other problem with kidneys is the actual nephron itself could be damaged, which is contributing to the blood pressure issues. So diabetic nephropathy is probably the most common one that we'll see from folks who have poorly controlled diabetes. So this is the nephron itself, and the problem with this is they have abnormal urine studies associated with it, because there's some kidney damage related to it, because they aren't functioning to filter out toxins and stuff like that as they should normally do. And then, of course, the RAS system, knowing this is important from a physiology standpoint, but also from a treatment standpoint, since a lot of our meds kind of address this system. So Renin is released from the kidney to convert angiotensinogen coming from the liver to angiotensin 1. Angiotensin converting enzymes released from the lungs, which will cleave angiotensin 1 and angiotensin 2. Angiotensin 2 then works two different ways to increase blood pressure. It works by a direct effect on the blood vessels themselves to cause a vasoconstriction. But then it also goes to the adrenal gland to cause it to release aldosterone, which then will go back to the kidney to increase the reabsorption of sodium and water by getting rid of potassium. So two different ways that you can regulate or cause an increased blood pressure using the RAS system. I know that's redundant, RAS system. But, that's important, especially when we start thinking about situations like hyperaldosteronism as far as adrenal gland disorders, where you're having a hypersecretion of aldosterone itself, which classic finding for that is going to be that poorly controlled blood pressure, but this unprovoked hypokalemia. So any patient with low potassium and hypertension, be thinking of hyperaldosteronism. And the way that you test this is, so you'll initially kind of do this, where you'll test the aldosterone to renin ratio. And again, if it's a abnormal secretion of aldosterone, that renin is going to be in the basement because the kidneys are going to recognize that the blood pressure is too high, and they're trying to decrease the blood pressure by decreasing the synthesis of renin or the release of renin. So if you still have aldosterone coming from a different source that's not responding to the release of renin and causing the conversion to angiotensin 2, that will be an inappropriate elevation, and that's going to be the initial laboratory finding for this condition. Cushing's is another adrenal gland disorder, and this is kind of a cortisol, excess cortisol. Lots of ways that this, some different ways that this can happen, from a pituitary adenoma to adenomas within the adrenal gland itself, to you taking excess steroids or glucocorticoids that triggers this hypersecretion of cortisol. And the initial test of choice is this dexamethasone suppression test. And then you could also do a 24-hour urine cortisol level, where they're collecting their urine and you're testing for how much cortisol is in the urine itself. And then this is just kind of the typical physical exam findings. So the red stria, the buffalo hump, the moon facies, the bruisability are all very typical of somebody with Cushing's syndrome. Another adrenal cause is a pheochromocytoma, which this is one that a lot of tests love, but you're going to see this classic triad of symptoms of headache, sweating, and tachycardia. It is diagnosed by this 24-hour urinary catecholamines or metanephrines. This works by these neuroendocrine tumors secreting catecholamines. So that's why that test will help you with the diagnosis, because you actually are picking up what the tumor is actually releasing. And again, this is just kind of a cartoon version of what you would expect with somebody with a pheo. It could be these neuroendocrine tumors are within the adrenal gland, but they really can be kind of anywhere in here. So it's not just the adrenal gland that you see it. That's just the classic or the typical place that you find it. But the classic triad of headache, sweating, and tachycardia, which they don't really even put there, but yeah, tachycardia, and then of course the blood pressure being elevated. Coarctation of the aorta. So we talked about this with congenital heart disease. So again, a narrowing of the aorta, where now the blood pressure is higher in the upper extremities and potentially lower in the lower extremities. So a hypertension in the upper to low or a normal blood pressure in the lower extremities. Rib notching, if you do an x-ray, you may see it on there, but just think of this as there's reduced blood flow down below because of this. And also be thinking of somebody who's younger who's having this diagnosis. Then there's endocrine causes, so hyperthyroidism. We have one of those cases in our lab on Friday. But hypothyroidism can also cause kind of an isolated diastolic hypertension. And they will have all the other symptoms that you would see with somebody with hypothyroidism. And then hyperparathyroidism can also cause it. Think of it as because they have all that extra calcium that is important for muscle contraction, and it just causes like an overstimulation of the smooth muscle cells to cause them to constrict. And then there's other things like sleep apnea that can cause you to have hypertension, and if you just control the sleep apnea, then the blood pressure gets under control. And then medication can also cause it. And then, of course, if you're in the illicit drugs, cocaine can also cause it. Alcohol, excessive alcohol intake can also cause it as well. So things that when you're counseling patients for lifestyle changes, things that they should be thinking about doing. And then the next definition or criteria that you really need to know is the definition of a hypertensive crisis, which is blood pressure like greater than 180 systolic or 120 diastolic. If it is this is then subdivided into a hypertensive urgency if you have these severe range blood pressures without evidence of end organ damage. Now, if you do have evidence of end organ damage, then this is called hypertensive emergency. And being able to clearly define which one you got will be important because of management guidelines, goals, and those types of things. What are the symptoms that you may see affecting the different organ systems if you have somebody with end organ failure? So if it's affecting the brain, then things that affect the central nervous system, so altered mental status, delirium, stroke, those kinds of things would be what you would see be described in those patients. Cardiac, I mean, yeah, if you have ischemic chest pain, that makes sense. But just having left atrial or left ventricular hypertrophy is a criteria for end organ damage. So if you do an EKG and you see that, then that would qualify as a hypertensive emergency. For the kidneys, you're going to see signs that they're kind of progressing into kidney failure, so increased creatinine, increased BUN, things that just show the kidneys are under stress, basically. And then the eyes, AV nicking, cotton wool spots, those kinds of things. Things that affect the retina so they can't clearly see, those would be all signs of a hypertensive crisis. The management guidelines, so in somebody who has an ASCVD risk of 10% or higher, then the blood pressure goal is recommended to be less than 130/80. So you're trying to get them out of that stage 1 hypertension range. If they don't have a high risk of ASCVD, it's reasonable to shoot for a blood pressure goal less than 130/80. If you can't get them quite less than 130/80, are you still okay? Yes, but it's reasonable for you to try to shoot for that goal. With treatment, lifestyle changes are important. All of these lifestyle changes can impact positively the blood pressure. Conversely, you can also say a lot of these things can actually hurt you. So if you're gaining weight or you're eating unhealthy, those kinds of things, they can all raise your blood pressure. But when we're talking about lifestyle management for blood pressure, these are things that you can do. But according to studies, the most effective single thing that you can do is the DASH diet. First line agents, so your ACEs, your ARBs, your thiazides, and your dihydropyridine calcium channel blockers are really the best first-line agents. ACE inhibitors, we already talked about the RAS system, and it works by blocking the conversion of angiotensin to angiotensin II, which the additional kind of positive to an ACE inhibitor is its effect on bradykinin. So bradykinin, if it's allowed to exist, will go into nitric oxide, which will have a localized vasodilatory effect. So two different ways that you really are, actually three ways if you will, in lowering your blood pressure by using an ACE inhibitor. The problem though is as this goes up, you then get cough as a potential side effect. So folks who don't tolerate ACE inhibitors, it's usually because of that bradykinin levels being too high. So that being the case, we do have a more localized medication called the angiotensin receptor blocker, angiotensin II receptor blocker, which has the same benefits as ACE inhibitors in the RAS itself, but it has no impact on the conversion of bradykinin to the inactive peptides. So you're still getting the breakdown of that, so you're not having that excessive bradykinin levels leading to a cough kind of side effect. For pregnant patients or those who are thinking about becoming pregnant, again, no ACEs or ARBs because of the risk of fetal harm. So you really are kind of truly limited to methyldopa, labetalol, and nifedipine as kind of your first-line agents for your pregnant or considering to become pregnant patients. The next agents, so thiazides, are great diuretics for blood pressure management. They have all the positive clinical outcomes, usually typically well tolerated except for maybe excessive urination, waking up at the middle of the night to go pee. But the key thing to kind of remember is if you have anybody with kidney failure or chronic kidney disease where the function is affected, this may not be the best agent for them because it won't have the same benefit to those patients. There's also lots of side effects as related to electrolytes, so you have to monitor electrolyte levels closely. Potassium sparing, so your spironolactone, not really used as a monotherapy agent because it doesn't do as good as the other agents in controlling blood pressure, but it can be used as an adjunct, especially in somebody who has like hyperaldosteronism. But the biggest thing you got to be careful of as far as side effects goes, hyperkalemia, especially if you're combining this with an ACE or an ARB, where the potassium levels go up because of that. So you have two agents basically that increase your potassium levels. So, yeah. And then your calcium channel blockers, especially the dihydropyridines, are really good at controlling blood pressure and are also considered a first-line agent. So amlodipine is a great blood pressure agent. Biggest risk, or biggest side effect for these that causes people to want to come off of them early is the ankle edema that they could experience. Alpha-1 adrenergic blocking agents, these are not ones that we use typically as a primary treatment. This is not a first-line agent. We are aware of them because really these are used for other things like benign prostatic hypertrophy in elderly males. But you have to be aware because if they have a history of hypertension or you're starting them on antihypertensives and they are on one of these agents because of their prostate, you have to be very careful because of the synergistic effect where you could be causing them to experience hypotension. So if your standard of care is to start somebody on 5 milligrams of amlodipine, but they happen to be taking one of these agents, you may need to cut it back to 2.5 milligrams or something like that, because that may be too much for them and may cause them to pass out, hit their head, and bleed. Alpha-2 agonists, again, not typically a primary or first-line treatment, except for if they're pregnant or they're in a hypertensive crisis. We'll use clonidine sometimes for those patients. So, we typically don't use these as first-line just because there's a lot of side effects kind of to them. So. And then beta adrenergic blocking agents, I mean, all of them have some impact on blood pressure. Not a ton, that's why beta blockers are not our primary agent, but labetalol is a great antihypertensive in certain situations like pregnancy, but also in hypertensive emergency where you have to lower blood pressure pretty quick. These are good agents for that, but not a first-line agent. And then, of course, hydralazine is also a direct-acting vasodilator. It works good, but not a first agent. It's usually considered adjunctive, but usually we're using it in like hypertensive emergency or again in pregnancy. Okay, and this was just talking about our goals. And then if you have a patient who's kind of in a special population, there may be medications that you would tend to make as your first line for those patients. So for our African American patients, be thinking more along like thiazide, diuretics, or calcium channel blockers, vice the ACEs and ARBs, because they tend to respond a lot better to calcium channel blockers in the thiazides. If you have a diabetic, because of the renal protective aspect of ACEs and ARBs, you may want to put them on one of those. If you have a patient who needs multiple medications, there's different tactics on how you can start them and raise the dosing of it. So you can either just put them on one agent and then get maximally dosed that one and then start a second one if you needed to. You could start one and then start another one at a later visit and then start titrating up to goal. Or you could also just start two at the same time and then follow up with them and get them to the goal. And then this is just for our patients who have chronic kidney disease. If they have evidence of like albuminuria or elevated creatinine, then they should be on an ACE inhibitor. And if they can't tolerate an ACE inhibitor, then put them on an ARB. And then if they have secondary hypertension, treat the cause of the secondary hypertension, which we didn't really go into too much detail on those things, but it makes sense if they have another condition that's causing it, go ahead and treat that one. And then the other thing to know is just which medicines, which classes of medicines, what are the electrolytes that you should be monitoring with those. And unfortunately, excluding this one, all of these are done. You can monitor in just a Chem7 and a BMP. For treatment guidelines, for urgency, typically, again, these are folks who have a severely elevated blood pressure, but no evidence of end organ damage. Typically, if they already are on oral agents, but they've stopped them, just restart it, have them follow up within 24, 48 hours to see their response. If they have the hypertensive emergency, so they have that evidence of end organ damage, this is somebody who is going to be admitted to the ICU for further monitoring and for treatment. Which if they have hypertensive emergency, the next thing you have to ask yourself to help you kind of from goal standpoint is this an aortic dissection? Is this preeclampsia, eclampsia, or is this a pheochromocytoma crisis? If the answer is no to any of those, then you want to reduce by 25%, or max of 25% over the first hour, then get them to 160 systolic over the next 2 to 6 hours, and then get them to normal over 24 to 48 hours. So it's a very gradual kind of decline. You just want that initial like 20-25% just so you stop harming the organs that are getting stressed because of the elevated blood pressures. If they do have any of those severe conditions or compelling conditions, then depending on which one, will kind of then determine what your goal is. So if you have pheochromocytoma or you have preeclampsia, then the goal is to get them less than 140 during the first hour. And then if they have an aortic dissection, the goal is to get them to less than 120 in that first hour. What agents can you use to really do this? So labetalol, nitric oxide, and nicardipine are kind of the preferred agents to really help with that. The one exception is for aortic dissection, where you're trying to be a lot more aggressive in lowering their blood pressure in that first hour. You're going to treat their pain and just see kind of the blood pressure response to just treating the pain, but then an esmolol drip will be appropriate to kind of get them down to goal. And then if you need to, there's other agents you can add on to that, but that's usually what we do. If they're cocaine or amphetamine abuse and they're coming in and seeing you, then you're going to be treating them with lorazepam and diazepam. You're not going to want to give them a beta blocker. If they're having a heart attack, it's interesting, but heart attack does not qualify you for the more aggressive blood pressure management. So the goal is initially 20 to 30%, like a 20% reduction, and then get them to 160 over the next couple of hours. And then you can do that by a nitroglycerin drip if you need to, and then you can also add on other agents like metoprolol to help lower that. Questions about hypertension treatment? Lipids. So lots of things that put you at risk for having elevated lipids. These are, the things that we typically think of. Of course, genetics can play a role in it too. So not much that you can do if they have a genetic history for it. The older you are, the more at risk you are of having an elevated cholesterol level. And then if you're a male, then those are factors that you can't really change to adjust your risk for it. But everything else, there are things that you can do, eating healthier, losing weight, being active, and all that, that can help reduce your risk of atherosclerosis. The anatomy of the blood vessels, so you got the intima, the media, and the adventitia, which all play a role in the development of an atherosclerotic plaque. To develop an atherosclerotic plaque, the first step usually is this fatty streak that forms in the lining of the intima. Then that results in the release of pro-inflammatory like cytokines and such that then causes a recruitment of not only other immune cells, but also the recruiting of like smooth muscle cells from the media, which then will kind of start to form that plaque. And then the final step is, because the body kind of knows that shouldn't be there, it starts to kind of break down some aspects of that plaque while it's also building up, and it becomes an unsteady plaque and can lead to a disruption of the plaque, which then can lead to a clot formation, which can cause the acute obstruction of the blood vessel. But fatty streaks, okay, that's just that. Foam cells are just the monocytes that come in that differentiate into macrophages. They just start to randomly start eating up all the LDL that they can find, but there's no control to it. They can't digest the LDL, so they just get to the point where they get bigger, 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 and then they rupture, which then triggers a more intense inflammatory reaction. and then plaque progression, plaque disruption. And then a cartoon version if you need it. Try to kind of understand what all the wording is on the previous slides. Definition, so dyslipidemia is an elevation of the LDL, the decrease in the HDL. Hyperlipidemia is both LDL and triglycerides are high. Hypercholesterolemia is if all you're concerned about is the total cholesterol. It doesn't break down if it's because of the good cholesterol or the bad cholesterol. It doesn't differentiate that. And then if you just have an isolated elevated triglycerides, then it's hypertriglyceridemia. So primary causes of elevated cholesterol or hyperlipidemia. So really this familial hypercholesterolemia, if it's kind of like an isolated LDL that's elevated. If it's combined, then you have both elevated triglycerides and LDL. But be thinking of this if you have a patient who has LDLs that are way off the charts. So if you have somebody who has an LDL of 500, be thinking that. If you have a patient with an LDL of like 160, yeah, maybe not this. But yeah, the significant elevations, be thinking that. The other thing would be if they have physical exam findings of cholesterol. So you have your xanthomas, like your eruptive xanthomas that you see here. You have your tendinous xanthomas, which is kind of these deposits that build up on the tendons, particularly of the extensor surfaces of the hands and the Achilles. You have the tuberous xanthomas on the elbows and the knees. And then the xanthelasma, this yellowing of the skin around the eyes itself. And then LDL can also get deposited into the iris as well. And you can get kind of this yellowish ring that forms along the periphery of the iris. If you go to diagnose them, how do you do it? Well, give fasting lipids, so you can see exactly what their LDL is, what their cholesterol is, and what their triglycerides are. But then you're also going to want to get liver function testing done just to kind of see if there's any evidence of liver stress. You're going to get a hemoglobin A1C, which will help you determine if they have diabetes, to help you kind of assess what their ASCVD really is if they don't have a diagnosis of it. And then you also are going to get a baseline creatinine kinase because of the side effects of statin therapy, where it can cause elevations in creatinine kinase. Lifestyle treatments are important, so lose weight, exercise, eat healthy. All that can help with lowering your cholesterol. But if you have to start them on statin therapy or on medications, statins are going to be your primary initial medications of choice. One, because they tend to be pretty well tolerated. Two, they tend to have a significant benefit compared to like just ezetimibe. And then also because the guidelines say these are the agents you should be starting off with. But these folks tend to have pretty good responses, positive clinical benefit by being on these meds. But the myalgias are one of the significant side effects to kind of look out for. So myalgias would just be like just muscle pain without elevations of any other things like the creatinine kinase. It'd be considered a myopathy if you start to have some elevations of creatinine kinase, but not a severe elevation. So you get maybe it's a little bit above normal. But it's not like a severe where it's greater than 10,000. If it gets to the point where it's a severe reaction to statins, then you can start to get rhabdo, which if they have that creatinine kinase that's severely elevated, greater than 10,000, you're also going to want to be checking the urinalysis for myoglobin, see if they have myoglobinuria, which will help you diagnose rhabdomyolysis. 'Cause, 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 If you do have a patient who starts to have a side effect of it, if it's just mild to moderate muscle symptoms, then you can discontinue the statin. You can restart it at a lower dose or just switch to a different statin, and that's okay. If they have a severe reaction to it, though, then you're going to want to keep them off of statin therapy, and that is an indication for that patient to be on a PCSK9 inhibitor as monotherapy if they just cannot tolerate statins. It's important for you to know the dosing of the medications to meet the definition of high intensity, moderate, and low intensity, just so that you can make sure that you have them on the right dose to meet the guidelines. So there was some confusion previously on, what is the dosing of like atorvastatin for a high intensity. It should be, this is 40 to 80 milligrams is high dose atorvastatin. And then rosuvastatin is 20 to 40 milligrams. That's a high intensity dose. Now, if you cut those, where now you're doing 10 to 20 milligrams of atorvastatin, that is a moderate intensity. 5 to 10 of rosuvastatin is a moderate intensity dose. So just know that, so that way on the test you'll know if it says on the algorithm to do moderate intensity, which dosing you're kind of thinking of for that. If statin therapy is not helping you get to goal, then a good adjunctive treatment is your ezetimibe or Zetia, and that is a good medication to put somebody on a statin to further help reduce it. We typically don't put somebody on this as a monotherapy because you're not really going to get the benefit from it. PCSK9 inhibitors are good for folks who you can't get to goal or if they can't tolerate statins. They are basically just as good at lowering cholesterol as your statins, but it is cost prohibitive, which is why they are not a primary agent for cholesterol treatment. Other definitions to know, so primary prevention is somebody who has never had a atherosclerotic cardiovascular disease, so you're trying to prevent them from ever having their first episode. And then secondary prevention is somebody who has had a atherosclerotic cardiovascular disease previously, and now you're trying to prevent them from having it progress and get more severe, or them to have a recurrence of the event. And then I will give you this on the test. So I don't expect you to memorize this chart, but just learning how to use it, which I think we had a good experience of walking through and using this chart during the lab. So it really just comes down to walking down the algorithms. Like for instance, for primary prevention, first step is you classify or categorize their LDL. Which of these three categories do they fit? So somebody with, an LDL less than 70 but has diabetes, does that really matter? And per this, it doesn't, because you already are less than 70. They don't need therapy. Even if they have diabetes, they don't need therapy if they're less than 70 already. Does that make sense? Risk enhancers, so things that, there's one where it's like a borderline risk, where you can look at risk enhancers to help further clarify if somebody needs treatment or not. What are the risk enhancers? So if they have like metabolic syndrome, then they're going to be at a higher risk. If there's a family history, if they persistently have elevated LDLs, these are all things that could put them at higher risk of having an ASCVD that may make you want to put them on a statin therapy earlier than if somebody didn't have those types of things. One of the, for secondary prevention, they categorize it based on, is this person very high risk or is this stable? And really what they're talking about with that is they're looking to see if they have 2 or more of these major ASCVD events. So if you think of 2 or more major are going to be like they had a heart attack, they had a stroke, they have peripheral arterial disease, those are all major factors or major events. If they only have like one of those, but they have it where they have diabetes or hypertension, or they're currently smoking, those are all risks, high risk conditions that can put them at a high risk of having a major ASCVD, or sorry, put them in a very high risk category for ASCVD. Because that will help you differentiate on the secondary prevention what your goals are on that. And then hypertriglyceridemia, so two categories. So moderate hypertriglyceridemia is you're elevated but less than 500, and then severe is it's greater than 500, which is important because we typically just do lifestyle stuff for this, and we do meds for severe. What are our meds? So our fibrates tend to be our primary one because they have a pretty good effect to it. Fenofibrate tends to be our initial go-to because the gemfibrozole can increase risk of increase our risk for rhabdo if they're on a statin therapy, especially. Niacin, it's good for raising HDL, but there is some benefit to LDL. And also benefit for lowering your triglycerides. But kind of be thinking of this as your primary treatment for this is going to be if you need to increase their HDL. Omega-3s, they're good at lowering triglycerides, but not it doesn't tend to be one of our first line kind of treatments for it. But if we do have somebody with hypertriglyceridemia, whether it be moderate or severe, you know, your dietary changes really are kind of our preferred treatment for it, which these are kind of things you're thinking about. It's just better fat selection, but lower quantity in general, and then probably eating more protein, more carbs than fat. Metabolic syndrome, it's a thing. You need 3 of these things to qualify for it. So basically you have to have abdominal circumference greater than certain values, elevated triglycerides, low HDLs, blood pressure, and diabetes or fasting glucose being elevated. Can all put you, if you have 3 of those being positive, that qualifies a diagnosis of metabolic syndrome. Let's go ahead and take 10 minutes and we'll finish up. Ischemic heart disease, which is kind of talking about like a spectrum of conditions. Really the gist of it comes down to ischemic heart disease is that the blood flow to the coronary arteries is diminished, which is going to then have an impact on the supply of blood to cardiac muscle. The heart itself can actually tolerate a pretty significant stenosis of the coronary arteries without really having any problems with it. But typically, once you get to about 70% stenosis, you start to have discomfort associated with exercise or stress. But then it tends to get better once you rest. Once you get to 90%, this is when you start to have symptoms at rest. So just kind of some general topic or ideas. But this is really just comes down to this dynamic of oxygen supply versus demand. And there's lots of things that kind of impact and go into these values. So when we talk about supply, the first factor is just the amount of oxygen in the blood to begin with that's getting to the heart. Typically this should be a constant unless there is some kind of pulmonary disease process that's going on that's causing you to not get that exchange of carbon dioxide exchanging carbon dioxide for oxygen. But other things that can influence it is the actual blood flow through the arteries and into the muscle itself, which you can have just the perfusion itself, but also, so this could be like your narrowing related to, or sorry, this could be related to the pressure of it, and then your vascular resistance. So it's just like, think of it as like a spasm of that. And then kind of subcategories of the peripheral resistance of the coronary arteries is, so contraction of the surrounding myocardium affects the blood flow to that area. If it's compressing, you get that external compression. And then what other regulatory factors we have acting on the coronary arteries at that time that either causes a vasoconstriction or a vasodilation. So those are things that kind of tend to affect the supply of blood to an area. As far as the demand, the ventricular wall stress, the higher the stress, the more blood that's necessary. And what factors kind of go into the stress? It's really the pressure that's inside and how far the myocytes are being pulled away from each other. Kind of really go into determining what the wall stress would be. And then the other things are how fast your heart rate is and how strong each beat is. Lots of things that can then go into actually impacting the supply and demand, a lot of medical conditions. And then some definitions. So stunned myocardium is basically myocardium that suffers from a transient ischemia, where it switches from a aerobic to an anaerobic metabolism because it's not getting the oxygen or as much oxygen as it needs. And the byproduct of that is you start getting all these toxic substances that kind of build up. Once that blood flow is then returned to that area of the heart may not start functioning right away because it's got to get rid of all those toxic substances first. But then eventually this myocardium will start functioning again once it kind of has overcome a lot of the stressors from that brief ischemia. Hibernating myocardium, on the other hand, is muscle cells that are getting just enough blood to stay alive, but not enough to actually function. So they're not squeezing, they're not moving blood, they're not doing anything, they're just kind of existing there and just taking up real estate and taking up nutrients and oxygen. This is important to note because after somebody suffers a heart attack where you get cell death, if there is areas of the heart that are hibernating, if I restore blood flow to that area, that muscle will start to function again and actually regain function. So that's why when we do cardiac stenting, hopefully we'll prevent cell death, but we're trying to get more blood flow to be able to recruit these cells to start functioning again. Variant angina, or angina, or Prinzmetal if you want to call it that, same thing. This is going to be somebody who looks like they're having a STEMI, smells like they're having a STEMI, but they're not having a STEMI. And it's because they're having the spasm of the coronary artery as opposed to it being from a blockage of blood flow. So these are folks that you're going to take them back to the cath lab and they are going to have completely clean coronary arteries. Because this is a spasm problem, sorry, this just shows you, this looks like an ST, looks like a STEMI while they're having pain, and then it goes away, or EKG goes back to normal after the pain resolves. But for treatment standpoint, because they're having this spasm, and that's the cause of this, you want to put them on a medication to prevent that spasm from happening in the first place. So your dihydropyridine calcium channel blockers tend to be your first-line agent, so your amlodipine tend to be your first-line agent for preventing this from happening. Nitro you'll use for acute management. So that's if they're having pain, they're having symptoms, you give them nitro and it will stop the spasm. But it's not something that you would want them on a nitro long term just to prevent it, because at least the calcium channel blockers can do a good job in eliminating this or decreasing the risk of spasm. Silent ischemia. So this is somebody who's having a heart attack but has no idea that they're having it. So they're having the obstruction, but they don't know they're having it. They're not having any pain. They're not having any other symptoms associated with it. So they're just having potentially the cell death happening without them knowing. What puts somebody at risk for having silent ischemia? So if they have like diabetes, like peripheral neuropathy, their nervous system is affected because of that. Elderly patients, and then women tend to be at a higher risk of silent ischemia. When we have angina, there's a spectrum of it. So stable angina is kind of the initial step to it. But then as, and this is categorized, by a stable plaque, but just a decreased perfusion, where basically, maybe they're at like a 70% stenosis of the coronary artery. They're going to have these symptoms with exertion, but then get better with rest. Now, the next step is really getting into your acute coronary syndromes, where now you have a plaque that's rupturing, and now you're having significant occlusion or perfusion defects. So, but we'll focus kind of on the stable angina aspect first. So, this is a chronic, predictable, transient chest discomfort. They have pain with exertion, but it gets better with rest. Other things like emotional stressors can also increase that oxygen demand temporarily, which can cause them to have symptoms. The pain that they typically describe is not that sharp stabbing pain, but it's more of a squeezing, tightness, elephant sitting on my chest kind of pain. Sometimes they can, maybe they don't have pain, but they start to display symptoms that are typically associated with like a increased sympathetic tone, where they can start having like tachycardia or sweating, nausea, shortness of breath. These are considered anginal equivalents if they experience these symptoms for no reason in the absence of chest pain. EKG, for like a stable angina patient, the EKG, you may see some non-specific kind of T-wave changes, but they don't have like a true stable angina is not going to have like a STEMI on EKG. Chest X-ray and echo are just going to be there to kind of rule out other things that are going on. You can get troponins just to make sure that they're not in an ACS event where they're having like an N-STEMI, and you're just not seeing it on the EKG, or you're not, EKG just has those non-specific changes, and they're just leaking troponins. So if you have somebody acutely with stable angina that you're seeing, get troponins, make sure they're not having an N-STEMI. Treatment, so they typically have pain with exertion, so get them to rest. You can give them some nitrates to help with the vasodilation and increase the supply of blood in that artery to kind of help treat the acute symptoms. But really, kind of our expertise comes from the chronic management of these patients, where you're going to have them do lifestyle changes, great, but for meds, you're going to have them really on a pretty wide range of medicines to treat not only the prevention of them having these recurrent stable angina attacks, but you're also going to have them on a medication regimen to prevent them from going on and developing a acute coronary syndrome. So what are they? So first line, beta blockers. Goal heart rate is 55 to 60, so titrating the dose to kind of get to the heart rate to that point. Beta blockers, the reason that these are first line are because they are the only ones that's documented to have an increased survival benefit. Contraindications to it, so if they already have a low heart rate, less than 55, then you can't really put them on it because they're already at goal for their heart rate. Calcium channel blockers are second line, but these are usually for patients who just cannot tolerate a beta blocker, or a beta blocker gets maximally dosed and you still can't get them to goal. Then you could throw them on a non-dihydropyridine medication to help. But calcium channel blockers typically are not first line. And we would prefer beta blockers if you could choose between the two. These folks can then also be on long-acting nitrates. So this is different than the acute setting treatment. So this is like your Nitroderm kind of preparations where it's like a transcutaneous medicine, but it just helps keep our coronary arteries dilated. And then ranolazine or Ranexa is also a great kind of agent that decreases the frequency of them having these anginal attacks, but it also helps improve their exercise tolerance, so they can kind of rehab better from this. Now, to prevent them from going on to developing an ACS event, if you recall, what kind of separates a ACS from stable angina is that rupture, that plaque rupture. And part of that plaque rupture is the formation of a clot. So when you put them on an antiplatelet therapy so they don't form clots as easily or as quickly. So you can either have them on aspirin, or if they cannot tolerate aspirin for whatever reason, you can have them on clopidogrel. You definitely are going to want them on a lipid agent. So they're at 70% stenosis right now. Well, let's prevent them from going on and developing a 90% stenosis. And then if they have diabetes, GLP-1s and SGLT2s actually have been shown to have a positive cardiovascular benefit. And then ACE inhibitors have been shown to reduce the risk of MIs, strokes, and death. So those are kind of our four main groups for the treatment to prevent ACS development. But for our patients who don't respond to treatment, you're doing maximal medication management, they're not responding, then you have your revascularization techniques, so your PCI, where they'll go in and then potentially put stents across areas of stenosis. Your bare metal stents, although better than a balloon dilation, the concern with them is restenosis. They're at risk for it. So they develop this drug-eluting stent that actually prevents that or delays that restenosis. If they get that drug-eluting stent, they're going to have to be on double antiplatelet therapy for at least 12 months, 6 to 12 months usually. And the reason you don't need, going back to the bare metal stents, the reason you don't need double antiplatelet therapy as long for a bare metal stent is that will quickly get incorporated into like a scar, and now you're not having that bare metal serving as a surface for clot formation. So they typically only need to be on double antiplatelet therapy for about a month or so after placement. Cabbages, so used to do a lot more of these, but PCI has become the preferred method if we can, but it's important to know who would benefit better from a cabbage. So if they have pretty significant disease of the coronary arteries, if they're diabetics, or they have like a large area that's affected from this, they may benefit by going and getting a cabbage done. And then the reason we're not more aggressive in treating stable angina patients with revascularization procedures is there's been no evidence that somebody who has chronic stable angina has a better outcome with PCI when compared to maximal medication management. So. Acute coronaries syndrome, so Your coronary arteries, they supply or they perfuse a specific area of the heart, which our EKG can help us kind of differentiate if we see changes, what coronary artery is being affected by it. So important to know the geographic distribution of the different arteries and what we would see on an EKG. Troponins are our biomarker of choice when we are blood testing these. If the initial one is negative, you're going to want to repeat it in like 3 to 6 hours just to see if it's trending in the wrong direction. So it may have been you got the blood test a little too early to actually pick up the cell death or the cell stress. A ST elevation is indicative of a transmural ischemia, so the whole thickness of the muscle is dying because of that. So think of an ST elevation as a more severe case. If you have T-wave inversions or ST segment depressions, then this is a subendocardial ischemia, so a more contained area that is being affected from decreased perfusion. What's your definition of an ST elevation? So greater than 0.1 millivolts in 2 contiguous leads, except if it's V2, V3. If it's V2, V3, you have a little more leeway for that elevation. Q waves, pathologic Q waves. These are the criteria for them. Typically, if you see pathologic Q waves, this is an indication that a heart attack occurred previously. It's not something that you see in the acute setting. I think typically it takes about at least several hours after the event for Q waves to start to develop. ST depressions, so that's just the segment of the ST segment is just depressed or lower down than what it should be. This could be a sign of like subendocardial ischemia, like you would see with like unstable angina or a non-ST elevation MI, but it could also be a reciprocal change if it were found in conjunction with a STEMI. The first stage of acute coronary syndrome is unstable angina, and what kind of differentiate this from the others is, so you get the rupture of the plaque, there's a partial occlusion, but you may have like T-wave inversions or ST depressions, but troponins are normal. And they remain normal on the repeat. An NSTEMI, so now this is also a partial occlusion, and you may have the T-wave inversions, ST depressions, and stuff like that. But the key thing is now your troponins are elevated in this condition. So this shows you that there is a more severe ischemia happening than you do with an unstable angina. And then with a STEMI, you have the actual ST elevations that you're seeing. It meets the definition of an ST elevation. It tends to be a transmural ischemia, and then you may have Q waves and you may have reciprocal changes associated with these. Treatment, so there's the pre-hospital stuff, so basically identify it early and communicate so that the hospital, the receiving hospital, can start coordinating the response team that they need. But if you can give aspirin, go ahead and give it as soon as you can. Make sure you record the time that it's given. Do they need oxygen? And do you have nitroglycerin to give to them once you've done an EKG? Would be important. But as long as you get aspirin going, that's kind of the first step for it. And then once they arrive in the hospital, you want to quickly identify this and get a lot of this stuff done in 10 minutes. What do I expect you to know about this? So if it's a STEMI, activate the STEMI. Give them oxygen if their oxygen level is less than 90%. Get a 12-lead EKG, check it, make sure it's good. And then if it's less than 12 hours since symptom onset, PCI less than 90 minutes of first medical contact is the time hack or the goal that you're shooting for. If you cannot meet that 90 and you can do it there in the facility, or if you have to transfer them to another facility, then you can do it within 120 minutes, then great, transfer them, get them there. But if you can't meet those goals, or you're worried that you might not meet this 120 minutes, then you may need to do fibrinolysis with like TPA to break up that clot and hopefully restore blood flow to the area. Does that time hack make sense to everybody? Okay. Some people with the the PCI say, door to balloon is 90, less than 90. So if you hear that, it's talking about going in and doing the PCI. If your EKG is an NSTEMI, a non-ST elevation ACS, then you really need to do like risk stratification to kind of see, is this a high risk or is this a low or intermediate risk? Because depending on what you find is going to kind of help determine the next steps. So if you have somebody who is high risk, then you may be thinking about invasive strategies much sooner. If they are low or intermediate risk, then you may just monitor them and then just have them go outpatient. How do you determine if they're high risk? Well, you're going to have scoring charts to do. So again, I don't expect you to memorize what is involved in a heart score, but just knowing, hey, if they're considered high risk, then they're going to have a score greater than 7. They're low or intermediate if they have a score less than 6. And then the TIMI score can be used to help guide you as far as what is the risk of dying in the next 14 days after experiencing a non-ST elevation ACS event. So the higher the score you have, the higher chance that you're going to die. So if you have a score of 6, you have a 41% risk of dying in the next 2 weeks. So treatment, aspirin. This is not something I expect you to remember the number, but this is just good to know why we use aspirin. Is there actually is some kind of mortality benefit when you get aspirin early. And then if you need to use fibrinolytic therapy, because you can't get PCI within that 90 minutes, then TPA is a good thing as long as there's no contraindications to using TPA. Nitroglycerin, after you've done your EKG and you have ruled out that they don't have a right ventricular infarction or they don't already have hypotension, then you can give them nitroglycerin to help alleviate their symptoms and hopefully dilate the blood vessels, restore blood supply. And then beta blockers, you're going to want to start these soon if you can, if there's no contraindication, because this has been shown to reduce post-MI cardiac remodeling, which will have a positive mortality benefit to a patient. Calcium channel blockers don't convey the same mortality benefit, so beta blockers, beta blockers, beta blockers. ACE inhibitors also prevent the ventricular remodeling, so they tend to have a long-term outcome benefit by being on an ACE inhibitor. And then, of course, statins are going to be important because they not only will prevent the progression of a plaque, but they also will stabilize the plaques that are there, so they are less likely to rupture and re-trigger an event. And then PCI, how do we do it? So what's the criteria for it? And then similar to what we talked about with the other lecture, what are our criteria for jumping straight to the cabbage as opposed to doing a PCI? There's lots of complications that are associated with a MI. It basically boils down to, if I had an MI and my muscle cells are dead, you're going to lose function in that area or in that region, so lots of things can happen. So I can start to form blood clots that get thrown to places, including up to the brain. I can go into cardiogenic shock, which causes my blood pressure to drop, which causes further cell death and just kind of this spiral of death that you see here. Depending on the area that is infarcted, it could impact my conduction system. So now I'm going to be more prone to developing arrhythmias that could cause further harm, further death. I could have pericarditis that develops. I could have bleeding into the pericardium itself and cause cardiac tamponade. And then if just too much of the heart muscle is impacted and it is now dead and now I don't have that function, now I'm going to start to develop heart failure because I just don't have enough muscle to circulate the blood necessary. And that's what all this kind of, these next couple slides talk about. Yeah. Okay. Yeah. Any questions about ACS or ischemic heart disease? Yeah. All right. Last two lectures. So aortic aneurysms. A true aneurysm is you get a dilation of all three layers of the artery. So you've got to have all three layers of the artery being impacted by it. That's bad, but it's not as bad as a pseudoaneurysm where you only have a dilation of the one layer, and it's because you have like a tearing of the other two layers, and now you only have one layer of the aortic wall, kind of keeping that pressure, keeping that blood inside of the aorta. So if you have a pseudoaneurysm, you're now like a ticking time bomb, and you're very prone to that actually rupturing. Abdominal aortic aneurysms are common. Be thinking males, smokers who have atherosclerosis. So those are your risk factors for a abdominal aortic aneurysm. A lot of folks tend to have tend to be asymptomatic. But if they start to have symptoms, pain in the abdomen tends to be one. But this pulsatile abdominal mass is something that maybe you're going to find actually on exam, or they're going to come to see you and they're going to complain about it. Physical exam again, yeah, you could palpate the pulsatile abdominal mass. Obviously, the bigger that is, the easier it will be to actually be able to palpate it. If you have a patient who you palpate that and you are concerned about it, get an ultrasound as long as they're stable. Get an ultrasound because you want to get an idea of what the true size of that is. Me just palpating a size, there could be a lot of it that I am missing, and I'm not going to be able to give you the, it could be that they meet the criteria to go to surgery that day, but I palpate it and they don't meet the criteria. So get an abdominal ultrasound to get a good idea of the size of that. USPSTF actually has recommendations for screening. So if you have a male who smoked at any point, doesn't matter how much they smoked, but they just smoked, then between the ages of 65 to 75, they should at least get one abdominal ultrasound screening done. If you have a male who has never smoked, there's no recommendation for or against it. For women who have never smoked, they actually recommend against getting screenings for this. But if you have a woman who has smoked, yeah, maybe they benefit from it, maybe not, don't know. You can just talk to your patients on that. But be thinking male smokers 65 to 75 should get at least one abdominal ultrasound done. Now, thoracic aortic aneurysms, be thinking of conditions that affect connective tissue. So your connective tissue disorders, be thinking this because of the weakness that those conditions will give to the media of the aorta. So it gives you that weakness of that layer. Kind of big things to think about. So it could be they're asymptomatic, but as that aneurysm gets bigger and bigger, it starts to press on important structures there in the chest. So they could have chest or back pain, but they could be having the recurrent laryngeal nerve or the phrenic nerve being compressed, and then they start to develop hoarseness or cough associated with it. Depending on the location of it, you may start to develop like an aortic regurgitation because it's pulling those aortic leaflets, the aortic valve leaflets apart, and now you're getting that regurgitation associated with it. And then also also blood pressure differences between the left and the right. X-ray, you may see a widened mediastinum with it, but the best test of choice is going to be echo, provided that they are stable enough for them to get the echocardiogram done. Treatment for a thoracic aortic aneurysm. So blood pressure control is important because you don't want to continue to have it dilate, but you also want to decrease the risk of it dissecting. And then, of course, the non-pharmacologic treatment of tobacco cessation, and then they may benefit from a statin therapy. For aortic aneurysms, so you're going to do that initial ultrasound, see where you're at. They don't meet the criteria for surgery, which in most patients is going to be a dilation of greater than 5.5 centimeters or a rate of enlargement of 1 centimeter in a year, greater than 1 centimeter in a year. Then they're going to be getting ultrasounds done every 6 to 12 months, just to make sure that they're not getting bigger. Now, a dissection is you now have a tear in the intima of the aortic wall, and now you're having blood that's kind of trapped in between the intima and the media, and it can extend down an extensive, region, and could be life-threatening because as it's doing that, it's also making that the integrity of the aortic wall decrease, and it could rupture. The big things that can cause it, so blunt chest trauma, we did it, or there was just an intimal tear because of pressure. So hypertension kind of leads you to this. So hypertension, we said, atherosclerosis, and then the other things that cause a weakening of the wall of the aorta can also put you at risk for a dissection. Type A, so again, we're not going to talk about DeBakey classification, but we're going to talk about Stanford type A's, Stanford type B's. Type A is if it involves any area that's proximal to the left subclavian, it is going to be a type A. If it only is present after the left subclavian, then that will be a type B. But it's more common to have a type A than it is to have a type B specific. How are our patients going to present if they have this? They're going to be complaining of this tearing or ripping sensation in either like the anterior chest or in the back or the abdomen, depending on where, if it is a type B, where that occurs. But the concern is that these can then also go and obstruct or affect the branches of major arteries off of the aorta, and now you start to have problems associated with those arteries being affected from this. You can get asymmetric blood pressures where there's a significant difference between the right and the left arm. They could be severely altered at that point. And then they also, especially if it is a ascending aortic dissection, it could also affect the aortic valve, and you're going to get this aortic regurgitation. Similar to a aortic aneurysm, but there's some other symptoms that kind of go and differentiate the dissection from an aneurysm. Typically, if we can, most experts are going to recommend a TEE if they're stable enough to get the TEE, but you may need other studies if they're unstable, i.e. a chest CT with contrast if they're unstable. Treatment, so they have an aortic dissection, let's admit them, let's give them pain control, let's control, we talked about with the hypertensive emergency, kind of what our goal is for that. Esmolol is going to be your initial treatment after you give them a morphine to titrate their blood pressure. If they have a type A dissection, they're going to go and get emergent surgery as soon as practical. If they're type B, typically you're going to try to manage them medically, although some patients are going to need to go get surgery. But the reason for kind of the difference in this is the mortality benefit by going and doing early surgery for a type A is significant. So they have a 25% chance of dying in the procedure if they get a type A, but or sorry, if they do surgery for a type A. But if you try to treat them medically, there's a 60% mortality. So there's a significant benefit by going and doing surgery than trying to just treat them medically. If they have a type B, it's the opposite, where medical management, there's a 9% risk of mortality associated with treating them just medically, whereas going and doing surgery, there's a 23% chance of dying just during the procedure. Okay, peripheral arterial diseases. So think of this as your stable angina for the arteries. It's chronic, same risk factors that put you at risk for stable angina also put you at risk for atherosclerotic disease. Basically, instead of a plaque being out in the coronary arteries, you have them in a peripheral artery. Claudication tends to be the most common presenting symptom for this. So this is somebody who they can walk a mile, they're okay. As soon as they hit 1.1 miles, they start to have cramping, dull pain kind of in the calves or in the legs themselves. Once they rest, it goes away, and they're better. And then tomorrow, the next day, they do it again. They can get a mile, no problem. But once they hit 1.1, they start having pain again. But this stable angina can progress, so it can get severe, and it can then equate to like an NSTEMI or even a STEMI by kind of this dry gangrene versus wet gangrene. How can you differentiate the severity of their symptoms to try to see if you can just do lifestyle changes versus actually going and doing a bypass surgery? Doing the ankle brachial index. So ABIs is important. Again, I'm not going to expect you to calculate an ABI, but just knowing what the differences are as far as what is abnormal, needs surgery versus what kind of is considered a normalish range. If you have somebody who has borderline or a normal ABI and are having these types of symptoms, initial treatments are going to be exercise training. So have them actually remain active, have them walk, have them test themselves to try to increase their endurance. But if they still have problems, then silostazol, Pletal is kind of your first line agent because it will actually help improve their symptoms and actually also improve their exercise tolerance. Statins, because they are going to be now listed as a secondary prevention patient, so you're going to need to follow that guideline for statin therapies as far as what your goal is and treatment and all that kind of stuff. Aspirin or Plavix, aspirin or clopidogrel are also indicated for peripheral arterial disease, and this just kind of keeps them from getting an acute occlusion causing acute limb ischemia, similar from the stable angina progressing to an NSTEMI kind of thing. If somebody does need surgery, typically what do? We do a bypass where you're basically bridging the, bringing good flow down past the obstruction to restore blood flow distal to that obstruction. Now, another form of peripheral arterial disease is your thromboembolic. So this is going to be your acute events where you get an acute obstruction, where if it happens in the limbs, you can get acute limb ischemia, or if it happens to like the intestines, you can have like an acute mesenteric ischemia. Kind of think of this as like the stroke of your limbs or your intestines. Usually these people are going to present with the 6 Ps. And then first thing you do when you try to treat it is, one, you're going to put them on some kind of anticoagulant to just cause a blood thinning to try to prevent a progression of that clot and further limit the blood flow obstruction. Then you're going to consult somebody to go in and retrieve that clot or that plaque, whatever broke up and went downstream. You're going to have somebody there to go get rid of it. And then they may do other things. They may do endovascular stenting, or they may even do a actual open surgery to do that. But ultimately, you got to get blood flow restored as soon as possible. And then if it's too far gone, you're left with just amputation or removal of the part that's affected. Vasculitis, so again, the only one that we really are required to talk about from a PANT standpoint is giant cell arteritis, which kind of think of this as cranial blood vessels, or cranial arteries that are affected. And depending on which one is affected will determine what symptoms you have. So if you have a temporal artery that's affected by this inflammatory condition, then you're going to have prominent headache with diminished temporal pulses. If you have the facial artery, then it's going to be like this claudication of the jaw, and if it's the ophthalmic artery, it's going to affect your vision. And then be thinking of elevated ESR, CRP, the inflammatory markers with this condition, and that will help you determine your treatment length and steroids. Vasospasm, so your Raynaud's kind of syndrome, very classic kind of color distinction or differences with this because of the spasm of the arteries themselves. Typically, the stereotype is either you're exposed to cold temperatures or severe emotional stress can trigger this spasm. The way we treat it usually is if they fit the bill for primary, so they don't have like another condition that's causing this like lupus, then avoid the cold, and then you could put them on a calcium channel blocker if you need to reduce that spasm. AVMs, arteriovenous malformations, so again, instead of having capillaries be kind of the intercessory thing between the arteries and the veins, you have an artery plugging directly into a vein. So now the vein is seeing a larger volume and a larger pressure than it is designed to, which will cause a dilation of the vein itself, which can cause some significant, especially cosmetic kind of conditions, but it could also run the risk of rupture. If you have a patient who has AVMs, do you need to treat them? Not necessarily, but if they want them treated or there's an indication to treat them, you can do embolization where you put things to kind of disrupt the blood flow to that area, or you can do sclerotherapy where you're kind of injecting a substance in there to get rid of those blood vessels. Any questions on the aortic diseases or peripheral arterial diseases? Well, let's finish up with peripheral venous disease. So classic one is DVT, deep venous thrombosis. What are our risk factors for it? So age, cancer, and immobility, because that is what's going to help lead us to develop Virchow's triad, where you get this venous stasis, something like immobilization, endothelial vascular damage, and hypercoagulability. That's going to make you more prone to develop clots inappropriately. There's distal and there's proximal DVTs. Distal have a lower risk of breaking up and going up to the heart and up to the lungs, whereas proximal have a higher risk of that happening. What are we going to see on exam? So you're going to see a unilateral extremity swelling, so the leg that is affected by that clot is going to be swollen, whereas the unaffected side is going to be normal in appearance. They may have Homan sign that's positive. You may be able to feel the venous cord from that clot if it's kind of extending all the way up. Wells criteria is used to help us kind of with management or diagnosis with it. If you have somebody who, when you plug in all the data into the calculator, they come as a low probability Wells score, you can do a D-dimer. If it's negative and they have a low probability, then the chances of them having a clot is highly unlikely and they do not need any further testing. If they are moderate or high probability Wells score, however, the next step is to do a compression ultrasound. So they actually are looking for blood clots in the deep venous system. If you have a diagnosis or if they see a clot doing that, great, you have your diagnosis, go ahead and treat. If the ultrasound is negative and you do a D-dimer and the D-dimer is positive, then you're going to want to just repeat in 1 week to see if a clot is now visible. But if the ultrasound is negative and the D-dimer is negative, even though they have this moderate or high probability well score, then DVT is basically ruled out at that point. For treatment, kind of the preferred thing is going to be your DOACs. Because of fewer interaction side effects, you don't need to monitor as closely like you do with warfarin. Warfarin used to be our preferred or our #1 treatment for it, but because of the complications associated with warfarin and the monitoring and everything like that, we now prefer DOACs if possible. But if other things you can do, so low molecular weight heparin injections, so your enoxaparin, your Lovenox injections can also be used. Just now requires the patient to give himself an injection twice a day. If you have a patient who it's contraindicated for them to get blood thinning medications or be on an anticoagulant, then you have your inferior vena cava filters, where they'll put this little cage-like thing into the inferior vena cava, and hopefully, if a clot were to break up and get sent up the inferior vena cava, this thing would catch it before it got up to the heart and up to the lungs. Superficial thrombophlebitis was another condition that we talked about. This is a benign condition. It's just an inflammation of a superficial vein. It could be in the situation of like they just had an IV placed. They're in the hospital and had an IV placed, and now they developed this. The workup for it is it's kind of minimal if you have an obvious diagnosis, but if you aren't sure, then yeah, you can do an ultrasound just to make sure there isn't a DVT that's there. But if you can confirm that it is a superficial thrombophlebitis, then the treatment is bed rest, heat, and compression. If it persists, then yeah, sure, they can go and get surgery done, but usually patients will respond to conservative treatments. The next condition we talked about was varicose veins, which everybody has seen these. We typically think of them as just involving the legs, but they also can involve lots of other regions. Big things that tend to put you at a risk for this is females standing for long periods of time, and then obesity. Typically, a lot of the times it's just purely a cosmetic concern, but patients, they can start to develop pain where you get kind of this diffuse aching, especially if you've been on your feet for long periods of time. They can start to develop this aching pain. You treat it by elevating the legs as much as you can, put them in, give them some compression stockings so that they don't have that dilation of the veins in the first place. They've got to be active because that will get the blood out of the legs and get it circulating again. But if they're having pain or not responding to conservative treatments, then there are surgical options that they can get to alleviate that. And then we're almost done. So chronic venous insufficiency is also something that's pretty common, which kind of think of this as this is now a chronic condition where you're having all this extra blood that's not getting out of the veins and up, that just causes basically for this extra pooling of blood into the legs itself. And it can cause a lot of chronic changes. You can see kind of this dermatitis and everything like that that develops. It's not something that happens acutely. This is kind of the venous side of the peripheral atherosclerotic arterial disease, the claudication kind of things. Typically these patients, they're going to have, this is worse with prolonged standing, but it improves with limb elevation and walking. They can get ulceration similar to the peripheral arterial diseases, but when you do have somebody with this, you are going to do an ultrasound but it's mostly there because you're trying to make sure that there isn't like a blood clot that's present. You do want to do an ABI on it just to make sure that this is not a arterial disease and that this is just a venous disease. How do you treat it? A lot of it's conservative, so exercise, compression stockings, and elevation. Those are going to be kind of your primary things. That, if they can avoid prolonged standing or sitting, that would be great. Because that skin, that dermatitis and everything that happens, that skin breakdown, you got to do good skin care. And then if they do start to develop ulcers, they have to be treated because it runs the risk of an infection and they can get septic from that. And then the final condition we talked about was lymphedema. So this is now an obstruction of lymph flow to return lymph back up to the heart. There's primary causes, but secondary causes are the most common that we'll see, which globally, it's usually a filariasis infection. But in the US, since we don't have filariasis, we're thinking more of things like postoperative, so an iatrogenic kind of cause, or malignancy, whether that be the malignancy itself or a complication of the treatments for that malignancy that led to this to develop. And usually you'll see like a unilateral extremity non-pitting edema, non-pitting, and then pain and such with that. But you can see the obvious differences between the two extremities with the pictures that are presented here. How do you treat it? Well, outside of traveling to an area that has filariasis, the things you can do are going to be avoid limb injury, external support if you need, if they have a condition already, go ahead and give them like compression sleeves and stuff like that to help get that fluid back up to the heart and so it doesn't sit there in the extremity. Have them exercise. It's like the arm, having them do like the arm bicycle kind of thing can help with that. Yeah, that's it. Questions?